First talk is on pearls in gonioscopy by Dr. Litta George. She's a glaucoma consultant in Tony's Eye Hospital, Aluva. She did her fellowship in glaucoma from Aravind Tirunelveli.
Very good morning to all. So my topic for discussion today is gonioscopy. It is a fundamental part of the comprehensive eye examination, and the basic purpose is to understand the topography of the anterior chamber angle. It is the gold standard against which all other angle imaging techniques are compared. However, it is one of the most neglected procedures in ophthalmology. In the beginning of the residency, everyone starts doing gonioscopy, find it as a cumbersome and messy procedure and just give up. Actually, with practice, it is a technique which can be easily mastered. The normal angle anatomy begins with the Schwalbe's line and extends up to the root of the iris posteriorly. In between, you have the non-pigmented and pigmented trabecular meshwork, the scleral spur, and the ciliary body band. Normally, the light from the angle undergoes total internal reflection. However, a gonio mirror eliminates total internal reflection by replacing the cornea-air interface by a new interface. So the gonioscopy can be indirect or direct. Indirect gonioscopy is the standard OPD examination technique. It is called indirect as the image is inverted, but to be noted, it is not laterally reversed. For the beginners to learn, it is always better to start using lens with flanges, the examples being the Goldman single mirror, the Goldman 2 mirror and 3 mirror lenses. These are also called as the scleral type of lenses. They have got a larger diameter and you need to use a coupling medium. They provide more stability and you will be able to visualize the structures properly. The technique always starts with precautions. It is important that you do gonioscopy in a dark room, and also the slit lamp gratitude height has to be less than 5 millimeter, otherwise there can be pupillar meiosis which can artifactually open up the angle. Examine the lens, see there are no cracks, apply the coupling agent. Take care to avoid bubbles, otherwise bubbles can come in between and obscure your view. Explain the procedure to the patient. Instill a drop of paraffin in both eyes. Place the chin of the patient on the chin rest with the forehead against the forehead band. Separate the upper and lower lids with your thumb and index finger and ask the patient to look up and insert the lens from below. Once you have learned gonioscopy, to make the procedure simpler, you have to switch to 4 mirror lenses, either a Posner, a Sussman or a Zeiss lenses. These lenses are also called as the corneal type of lenses. Here you need not use a coupling agent. You can just instill a drop of paraffin and straight away place the lens. This procedure is more comfortable both for the examiner as well as for the patient, and it is less time consuming. Direct gonioscopy, mainly it is an OT examination technique. Earlier it was mainly used for congenital glaucomas for the procedure of goniotomy, but now with the advent of minimally invasive procedure, there is an emerging interest in direct gonioscopy. Most of the minimally invasive procedures are angle-based surgeries and they require a mastery over the skill of direct gonioscopy. The examples are the Barkin Scopies and the Swan-Jacob lenses. So while doing gonioscopy, first estimate the width of the angle, see whether it's an closed or an open angle, see the level of iris insertion, look for the profile of the peripheral iris, whether it's a concave, convex or a flat iris. Concave configuration you get in pigment dispersion syndrome following cataract surgery and even in myopes. Convex configuration is the one which you observe in angle closure glaucoma, and in flat iris insertion is noted in plateau iris syndrome. See the degree of trabecular meshwork pigmentation. Hyperpigmented trab you can get in conditions of pigment dispersion, pseudo-exfoliation following cataract surgery, inflammation, etc. In young patients, the trabecular meshwork may not be pigmented, so you can easily misdiagnose it as a closed angle. So always identify the Schwalbe's line using a corneal wedge, and also identify areas of iridotrabecular apposition or synecdoche. If the pigmented trabecular meshwork is not visible without manipulation or indentation in at least 3 quadrants, it is called as an occludable angle. Then you have to do a dynamic gonioscopy, which can either be a manipulation or an indentation gonioscopy. Manipulation gonioscopy is the one which you do with your 2 mirror lenses. Here either you can ask the patient to look towards the mirror or you can tilt the lens towards the angle. Indentation gonioscopy is done with the 4 mirror lenses. Here with the lens you exert an axial pressure in the central cornea which pushes the aqueous to both sides, and in case of appositional closure this opens up the angle. Gonioscopy should be avoided in conditions of acute infections, in case of bullae on cornea and in post-traumatic eyes. You have different grading systems like Schaeffer's, Shear, Spades, and RP Center. In Schaeffer's, based on the geometric angle width, there are 4 basic grades. Grade 4 and grade 3 are open angles, where almost all angle structures are visible, and grade 1 and 0 are closed angles. However, Shear's grading is just the reverse. Here, the grade 4 is the most occludable one. So it is better to mention the structure which has been visualized in order to avoid confusion. So now certain clinical scenarios. One confusion you can get is regarding the peripheral anterior synecdoche and iris processes. These iris processes are thin filiform structures. They do not cross the trabecular meshwork and do not obscure the view of the underlying angle structures. As opposed to this, the peripheral anterior synecdoche, they are broad, irregular, hyperpigmented. They cross the trabecular meshwork. They can extend to any level even beyond the Schwalbe's line. And they cause functional obstruction for the aqueous drainage. Plateau iris, here the iris exhibit a flat approach to the angle. And what we see is a sine wave pattern. In pigment dispersion, you can get a uniformly hyperpigmented trap in all the 4 quadrants, which is referred to as the mascara line. There is also a hyperpigmented Schwalbe's known as the Sample-Assis line. In pseudo-exfoliation, there is excessive pigment dispersion. However, the trabecular meshwork is not as uniformly pigmented as in pigment dispersion. And here, the pigmentation is more in the inferior angle. You can also get pseudo-exfoliative material in the trabecular meshwork itself. In neovascular glaucoma, you get fine arborizing vessels over the trabecular meshwork. These vessels are branching and fine. As opposed to this, the normal angle vessels, they have got a greater caliber. They are usually single in number. In angle recession, you get a widened ciliary body band. Here, it is always advisable to do gonioscopy of the normal eye first, so as to get an idea regarding the width of the ciliary body band, as ciliary body band may be normally visible in myopes. So to conclude, gonioscopy is mandatory in the diagnosis and treatment of glaucoma. To master it, start doing and keep doing.